I'm Timoor Mostafa, Assistant Professor of Cardiology at Tanta University. Today we talk about one form of the valvular heart disease, which is the mitral valve regurg. We start with the valve anatomy. The mitral valve connects the left atrium with the left ventricle, and the mitral valve opens during diastole to allow the blood to flow from the left atrium to the left ventricle. During systole, the mitral valve closes and prevents backflow to the left atrium. The normal function of the mitral valve depends on its 6 components, which are the left atrial wall, the annulus, the leaflets, the chordae tendineae, the papillary muscles, and the left ventricular wall. And this diagram shows us each part of the anatomy of the mitral valve. What about mitral regurg? It's defined as the abnormal reversal of blood flow from the left ventricle to the left atrium, and it's caused by disruption in any part of the mitral valve apparatus. Epidemiology. It affects approximately 5 in 10,000 people. In industrialized countries, it ranks second among valve disease after aortic stenosis and affects 9.3% of the patients or the persons above the age of 75 years. It is the first most frequent left-sided valve disease in the community and second in hospitalized patients. It is the second most frequent indication for valve surgery in Europe. What about the etiology? We have 2 etiologies, the primary or secondary. Primary, one or several components of the mitral valve apparatus are directly affected, and it is the most frequent etiology is degenerative, like in rheumatic heart disease, like we see in Egypt, like prolapse, flail leaflet, and also endocarditis is one of the causes of the primary mitral regurg. Secondary, which was previously named functional mitral regurg, the valve leaflets and the chordae are structurally normal, and the regurg results from an imbalance between the closing and the tethering force of the valve, secondary to alteration of the left ventricular geometry. We see this a lot in patients with ischemic or dilated cardiomyopathy. Also, annular dilatation in patients with chronic atrial fibrillation and left atrial enlargement can be a cause or another underlying mechanism. We can also classify mitral regurg into acute and chronic mitral regurg. Acute, it may be due to annular disorder like endocarditis, trauma, paravalvular leak. It may be caused by leaflet disorder like endocarditis, trauma, atrial myxoma, myxomatous degeneration, and Liebman-Sachs syndrome. Rupture of the chordae tendineae, which may be spontaneous or due to myxomatous degeneration or endocarditis. It may be caused by acute rheumatic fever or trauma. Also, papillary muscle disorder can cause acute mitral regurg due to acute coronary syndromes, acute left ventricular dysfunction, infiltrative diseases like sarcoidosis and amyloidosis, and trauma. Last cause for primary affection is the primary mitral valve prosthetic disorders like cusp perforation, degeneration, mechanical failure, and immobilized disc or ball. Regarding the causes of chronic mitral regurg, it may be inflammatory like rheumatic heart disease, lupus, scleroderma. It may be degenerative like myxomatous degeneration, Marfan, Ehlers-Danlos, pseudoxanthoma elasticum, calcification of the mitral annulus. It may be infective endocarditis. It may be structural like rupture of the chordae tendineae, rupture or dysfunction of the papillary muscles, dilatation of the mitral valve annulus and left ventricular cavity, hypertrophic cardiomyopathy, paravalvular prosthetic leak. Last reason for chronic mitral regurgitation is the congenital reasons, which are like mitral valve cleftlets or fenestrations, parachute mitral valve, TGA, and anomalous origin of the left coronary artery. Now we have what's called Carpentier functional classification. Actually, Carpentier's functional classification is very important because it gives us an idea about the mechanism of valvular dysfunction. It's classified into type 1, which has normal leaflet motion, type 2 with excess leaflet motion, type 3 with restricted leaflet motion, and it's classified into A with restricted opening, B restricted closure. In type 1 mitral regurg, valve insufficiency occurs secondary to annular dilatation or leaflet perforation with normal leaflet motion. While in type 2 is seen as patient with mitral valve prolapse and is due to prolapse of often thickened excessive leaflet, frequently in addition to ruptured or elongated chordae tendineae, causing increased leaflet motion. While in type 3 insufficiency, as seen in patients with rheumatic heart disease and ischemic heart disease, it's due to restriction of the leaflet motion, which may be during systole and diastole, like in type 3A, or only in systole like in type 3b. And this table shows us the dysfunction, the lesion, and the etiology of each of the Carpentier classification types. Also, these photos show different types of Carpentier classification. What about the pathophysiology? In acute mitral regurg, mostly seen with spontaneous papillary muscle rupture or chorditendine rupture during the course of myocardial infarction. There will be volume overload on unprepared left ventricle and left atrium, leading to increasing left ventricle filling pressure, increased left air pressure, and it will end by acute pulmonary edema. What about chronic mitral regurg? Then a volume overload is imposed on the left ventricle and the left atrium, increasing the left ventricular end-diastolic pressure and the left atrial pressure. So there will be compensatory dilatation of the left atrium and the left ventricle to accommodate this volume overload at low pressures. Left ventricular hypertrophy will occur and left ventricular dilatation. The increased preload, left ventricular hypertrophy, and reduced or normal afterload will occur. So there will be a large stroke volume. But we also have what's called mitral regurg, brings more mitral regurg. It will cause more left ventricular dilatation, annular dilatation, and so we will have more mitral regurg. It will end by contractile dysfunction, reduction of ejection fraction, and increase in the end systolic volume, increasing the left ventricular end diastolic pressure and volumes, and increase in the left atrial pressure. So finally, we'll have a reduced forward stroke volume and cardiac output, and we will have also pulmonary congestion and pulmonary hypertension. And this diagram shows us the normal on the left side. In the middle, we can see the acute mitral regurgitation with high left atrial pressure, chronic mitral regurgitation on the right side with dilated left atrium with normal pressure. What about the history? Acute, when associated with MI, significant acute mitral regurg is accompanied by symptoms of impaired left ventricular function like dyspnea, fatigue, and orthopnea. In these cases, pulmonary edema is often the initial presentation. What about chronic cases? It may be symptomatic for years. But when symptoms develop, it's due to left ventricular systolic dysfunction. When it develops, patient will have fatigue, dyspnea on exertion, or shortness of breath. Patient may feel palpitation if he develops atrial fibrillation. Patient with left ventricular enlargement and more severe disease eventually progress to symptomatic congestive heart failure. What about physical examination? Auscultation, first heart sound is usually soft. Apex laterally displaced and often with heave. We have a high-pitched hollow systolic murmur heard at the apex and radiating to the axilla. In case of mitral valve prolapse, may be all over the precordium, and it's heard best when lying on the left side. And we all know that the direction of regurgent jet will show us where the murmur is radiating. In case of mitral leaflet prolapse, a systolic click might be heard. Third heart sound is commonly heard, and atrial fibrillation may be present. What about the ECG? When the patient has a left atrial enlargement, there will be a P-mitral. Sometimes we have atrial fibrillation, and sometimes we have the features of left ventricular hypertrophy. X-ray is a very important part of the diagnosis, showing left ventricular enlargement. It may show left atrial enlargement, and we may show also pulmonary venous congestion. What about echocardiography? I think echocardiography is the most important part of the examination of the patient with mitral regurgitation, because as we will see, it would help us to know the diagnosis, severity, the strategy plan for this patient. So echocardiography is important for assessment of mitral valve anatomy to understand the etiology and the mechanism of mitral regurg, assessment of mitral regurg severity, detection of impact on the left ventricular size and function, guiding the selection of therapeutic strategy. Okay, let's go one by one. Assessment of mitral valve anatomy. All components of the mitral valve apparatus, leaflets, annulus, chordae, papillary muscles, and the left ventricle will be evaluated carefully. Based on this evaluation, it's possible to differentiate between primary and secondary chronic mitral regurgitation. In chronic secondary mitral regurgitation, the mitral valve is usually normal, and the underlying mechanism is severe left ventricular dysfunction that leads to papillary muscle displacement and leaflet tethering with associated annular dilatation and prevent coaptation. In chronic primary mitral regurg, echocardiography helps in detailed assessment of the mitral valve leaflets to diagnose prolapsed scallops, flail leaflet, perforation, vegetation, detailed assessment of the subvalvular apparatus to diagnose ruptured chordae, ruptured papillary muscles. Okay, what about chronic secondary mitral regurgitation? Echocardiography helps in measurement of the left ventricular size and ejection fraction, assessment of the global and the regional left ventricular wall motion abnormalities, tethering of the mitral valve leaflet due to papillary muscle displacement, symmetric or asymmetric mitral annular dilatation. Let's go for one of the very important steps during echocardiographic evaluation, which is the assessment of severity of mitral regurgitation. We have three ways of assessment: a qualitative method, semi-quantitative method, and a quantitative method. First one is the qualitative assessment. We have two ways to assess. First is the density of the mitral regurg signals using the continuous wave Doppler. When you have a flow, density is similar to the antegrade flow, so definitely you have a severe mitral regurg. When you have a faint flow, you will have mild mitral regurg. Second way for assessment by qualitative way is the color flow jet 2 of mitral regurg. A color Doppler imaging mitral regurg jet indicates the presence of mitral regurg. Direction of the mitral regurg jet can help in mechanism identification. For example, in mitral regurg secondary to leaflet tethering, the regurgent jet is towards the restricted leaflet, while in prolapse it is away from the prolapsed leaflet. In case of normal mitral valve structure, normal left ventricle and left atrial size, a small central jet of less than 4 cm square or less than 10% of the left atrial area in multiple views is usually mild mitral regurg. Let's go to the second way, which is the semi-quantitative assessment. We have many ways. We go with the vena contracta width. What is the vena contracta? It is the smallest, highest velocity region of a flow jet and is typically located at or near the regurgent orifice, which means the mitral valve. It can be used for central and eccentric jets and accurate in acute mitral regurg. When you have a vena contracta width less than 0.3, it's mild mitral regurg. More than 0.7, it's severe. And in between will be the moderate mitral regurg, which will need another way for assessment. And this is a photo showing the vena contracta. What about the second one, which is the pulmonary venous flow reversal? The reduction of systolic velocity in more than one pulmonary vein and even reversal of flow indicates severe mitral regurg. However, increased left atrial pressure of any reason may result in blunted pulmonary venous systolic flow. So, absence of flow reversal should not be used for exclusion of significant mitral regurg. It can be a false negative. Why? If the jet is directed away from the pulmonary veins, you may not have flow reversal. On the other side, if the mitral regurg jet is small but eccentric and is directed towards the pulmonary vein, you may have blunted or reversal of flow, which we call it false positive. Third way is the peak velocity of E wave. A velocity of more than 1.5 meter per second indicate severe mitral regurg. Last one is the regurgent index, which is the quantification of pure isolated organic mitral regurg. We do what we call velocity time integral from the mitral to aorta. A ratio of more than 1.4 defines patient with severe mitral regurg. Last way of assessment is the quantitative assessment. We have the effective regurgent orifice area. First, we should know the PISA, the flow deceleration proximal to the regurgitant orifice, concentric proximal isovelocity surface area. And now we can measure the regurgitant orifice area. If less than 0.2 centimeters square indicates mild mitral regurg. If it's more than 0.4 indicates severe mitral regurg. A regurgent volume of less than 30 milli per beat indicates mild. More than 60 means severe mitral regurg. And here we can see the region of the PISA, the vena contracta, the regurgent jet area on the photo on the left side. What about the final way, which is the quantitative assessment? We have the volumetric measurement, quantification of regurgent volume and the regurgent fraction. And it's based on calculation of the stroke volume across the mitral valve and across another non-regurgitant valve like the aorta or the pulmonary. A regurgent fraction of less than 30% indicates mild mitral regurg. More than or equal to 50% indicate severe mitral regurg. In this table, we summarize the criteria of severe mitral regurg by the semi-quantitative assessment and by the quantitative assessment. Using the semi-quantitative assessment by vena contracta more than 7, systolic flow reversal in pulmonary arteries, in the pulmonary veins, E-wave velocity more than 1.5 meter per second, and time velocity integral of the mitral to the aorta more than 1.4. These are the semi-quantitative ways to detect severe mitral regurgitation. While the quantitative assessment, effective regurgitant orifice area of more than 40 for primary or more than 20 for secondary mitral regurgitation, regurgitant volume of more than 60 for primary and more than 30 for secondary indicates severe mitral regurgitation. Now we finished the echocardiogram and its important role for patients with mitral regurgitation. Do exercise testing has a role? Yes, it can be useful for assessment of functional states and symptom elicitation. And the exercise echocardiography may reveal elevated pulmonary artery pressure, mitral regurgitation worsening, blunted left ventricular or right ventricular contractile reserve. What about the TEE? ACCHA class 1 indications for performing a TEE. You can assess the etiology of severe mitral regurgitation in patients for whom surgery is recommended to determine the feasibility of valve repair. You want to know you can do repair, so you do a TEE. Evaluation of mitral valve and associated structures in patients for whom transthoracic is non-diagnostic. What about the CMR? It's the gold standard for evaluation of dimensions and the function in the cardiac chambers. You can also evaluate the myocardium. A left ventricular end-diastolic volume index of less than 100 estimated by CMR can be a predicting factor of freedom from surgery in patients with moderate or severe mitral regurgitation. Evaluation of myocardial viability and infarct site is very important to guide for the strategy. And finally, the regurgitant volume and regurgitant fraction can be quantified. What about the CT? Evaluation of the mitral annulus geometry and dynamic changes, calcification site and extent, identification of the relationship of mitral valve and surrounding structures, guide the axis for transapical puncture. So it's very important for guidance of percutaneous interventions. Also, determine the effective regurgitant orifice area, prolapse and flail parameters, tethering angles, and interpapillary muscle distance. Cardiac catheterization, does it have a role in patient with mitral regurgitation? Yeah, according to the ACCHA class 1 indications for performing cardiac catheterization. Left ventriculography and hemodynamic measurement in number 1, non-invasive tests are inconclusive regarding the severity of mitral regurgitation, left ventricular function, or the need for surgery. Number 2, the clinical and the non-invasive findings are conflicting regarding the grade of severity. So if you don't know the grade of severity accurately, you can do left ventriculography. What about the hemodynamic measurements? When pulmonary artery pressure is out of proportion to the severity of mitral regurgitation, assessment by non-invasive testing. Coronary angiography, yes, before mitral valve repair or replacement in patient at high risk for coronary disease, or when the mitral regurgitation is suspected to be ischemic in origin. So we know all the diagnostic tools we can use for proper diagnosis of patients with mitral regurgitation. Now let's go for the treatment. Factors affecting decision making include mitral regurgitation time, severity, hemodynamic consequences, disease stage, patient comorbidities, and the experience of the heart valve fatigue, which is very important. Principal intervention for primary mitral regurgitation is surgery. However, transcatheter mitral valve repair using edge-to-edge clip plays a very limited role. Whenever feasible, mitral valve repair is strongly preferred over mitral valve replacement for primary mitral regurgitation. While surgical treatment for secondary mitral regurgitation should be considered only after appropriate medical and device therapy have been instituted. So, surgery it is mainstay of treatment in primary mitral regurgitation, while secondary mitral regurgitation it comes next to medical treatment and device therapy. What about medical therapy? For patients with acute mitral regurgitation caused by MI or infective endocarditis, early diagnosis and ECG, echocardiogram proper therapy should be initiated. For any patient with acute or chronic mitral valve regurgitation with hemodynamic compromise should be evaluated to rule out acute myocardial infarction. Diuretics is administered for patients with pulmonary congestion. Afterload reducing agent like nitrates and antihypertensive agent are helpful for maintaining a forward cardiac output in patients with mitral regurgitation with symptoms of heart failure. Beta blockers and spironolactone, when indicated, can be used. In patients with atrial fibrillation, beta blockers, calcium channel blockers, or digitalis should be considered. The same patient with atrial fibrillation, you should consider for anticoagulation. Intra-aortic balloon counterpulsation and entropic agent should be considered in the patient with acute mitral regurg and hemodynamic compromise. Definitely, endocarditis prophylaxis is very important to remember in all patients with valvular heart disease. What about the guidelines? What the guidelines say in patients with severe primary mitral regurg? Class 1C, mitral valve repair should be preferred technique when the results are expected to be durable. Surgery indicated in symptomatic patient when ejection fraction is more than 30%. In asymptomatic patient, you should consider surgery if ejection fraction is less than 60% or left ventricular end systolic diameter more than 45 mm. Surgery should be considered in asymptomatic patient with preserved left ventricular function, ejection fraction more than 60 and systolic dimension less than 45, and atrial fibrillation secondary to mitral regurg or systolic pulmonary artery pressure is more than 50. Surgery should be considered in asymptomatic patient with preserved left ventricular ejection fraction when a durable repair is likely. Surgical risk is low, so repair is performed in a heart valve center and at least one of the findings is present: flare leaflet or presence of a significant left atrial dilatation with sinus rhythm. Mitral valve repair should be considered in symptomatic patient with severe left ventricular dysfunction, we mean ejection fraction less than 30 or end systolic dimension more than 55, refractory to medical therapy, when the likelihood of successful repair is high and the comorbidities low. Mitral valve replacement should be considered in symptomatic patient with severe left ventricular dysfunction, ejection fraction less than 30, and systolic dimension more than 55, refractory to medical therapy, when the likelihood of successful repair is low and the comorbidity low. Percutaneous edge-to-edge repair in patient with symptoms, severe mitral regurg who fulfill the echocardiographic eligibility for percutaneous intervention or at high surgical risk by the heart team, avoiding fertility. What about the indication of mitral valve intervention in chronic secondary mitral regurg? Surgery in patient with severe mitral regurg undergoing CABG and ejection fraction more than 30%. In symptomatic patient with severe secondary mitral regurg with ejection fraction less than 30 but with an option for revascularization and the evidence of viability. When revascularization is not indicated, we can consider surgery with severe mitral regurg with ejection fraction more than 30% who remain symptomatic despite optimal medical therapy, including CRT, and they have a low surgical risk. When revascularization is not indicated and the surgical risk is not low, a percutaneous edge-to-edge procedure may be considered in patient with severe mitral regurg with ejection fraction more than 30% who remain symptomatic after optimal medical therapy plus CRT. In patient with severe secondary mitral regurg and ejection fraction less than 30 who remain symptomatic despite optimal treatment plus CRT and who have no option for revascularization, heart team may consider a percutaneous edge-to-edge procedure or valve surgery after careful evaluation. Key points. Echocardiography, it's very important and its role is crucial in evaluation with valvular heart disease, especially mitral regurgitation. It can assess etiology, valve anatomy and function. An integrative approach is needed to assess severity of mitral regurg. You can use more than one way. You cannot judge by only one way to say is this a severe mitral regurg or not, because this will be a base for your strategy and plan for treatment. Indication for intervention in primary mitral regurg is guided by symptoms and risk stratification that include assessment of left ventricular function and size, atrial fibrillation, systolic pulmonary artery pressure, and left atrial size. This is very important for decision making. Patient symptomatic or not, and what about the risk stratification? What about the left ventricular size and function? Is the patient in sinus rhythm or atrial fibrillation, systolic pulmonary artery pressure, and the left atrial side? In secondary mitral regurg, no conclusive evidence for a survival benefit after mitral valve intervention. Surgery, it's recommended in patients with an indication for CABG and may be considered in patients who are symptomatic despite optimal medical therapy, including CRT, as we said before, or have a low surgical risk when revascularization is not indicated. Mitral valve repair is the preferred method, but mitral valve replacement should be considered in patients with unfavorable morphological characteristics. Outcomes of mitral valve repair depend on the surgeon experience and center-related volume. Percutaneous edge-to-edge repair may be considered in patients with high surgical risk and avoiding fertility. Thank you.